goodness, today we are having a webinar with David Blane, who is a senior clinical lecturer in general practice and primary care at the University of Glasgow, and also the academic coordinator of the Deep-End GP group in Glasgow. The webinar, as you know, is what is the role of primary care in mitigating health inequalities and strengthening social cohesion. On a very practical note, I would like to ask everybody to mute themselves during the presentation, of course, put the cameras on, as it's quite nice to actually see people. At the same time, the meeting is being recorded, so if you are uncomfortable with that you do what you need to do. And yeah, I think that is for now. Welcome to the people arriving now, and we will just start. Thank you very much, David.
Thank you, Sophie, and thank you others for joining. So yeah, quite nice to have a small group, because hopefully we can have some more interaction. And I've got quite a gentle start to the presentation as well. So I'm going to start with a little bit of interaction. This is about social cohesion. So I want to do two things to start with. I want you to go to menti.com. If you can either do that on your computer and type in that code 83453282, or you can use your phones if you prefer and just do it on your mobile phone, taking a picture of the QR code. So there's two ways to join the Menti. So the question is about, what do you think the potential for primary care to A, mitigate health inequalities, and B, strengthen social cohesion is? That's my question for you. That's the first task. So I'm going to leave that up for a moment and then see if we have any responses. Is anyone see?
It just appeared on my phone, so I'm now going to answer, David. So wait a minute.
Okay. Do you know what? I can do it on this link as well. It's maybe easier. Okay, so you have this distribution here of responses so far. This sort of activity works better when there's probably greater numbers, but I mean, even just an indicative sense of those that are here so far can show that there's a high level of agreement that primary care can mitigate health inequalities and it can strengthen social cohesion. So that's a nice starting point for us. So the other thing that I wanted to do, again in the spirit of social cohesion, is to ask if you could put your name in the chat and where you're from, and perhaps what made you interested in this topic, and then I'll persevere with the presentation. Okay. So this is what I'm going to cover today. I'm going to start with some definitions. So what do we mean by health inequalities? What do we mean by social cohesion? And then I'm going to speak a little bit about the role of primary care and introduce a framework and some principles based on recent research. And then I'm going to say a little bit about my own experience through involvement of the Scottish Deep-End project over the last 13 years or so. And actually that's kind of where I'm going to start as well, because I've got a few acknowledgements with regard to the Scottish Deep-End project. And this is our steering group at one of the meetings just pre-COVID. Most of our meetings since have been online, but this has been the kind of the beating heart of the Deep-End group. And I think in terms of social cohesion, certainly for the practitioners involved, I'll say a little bit more about later, but I think that's been one of the really powerful elements of the group. Also to say we've had financial support from the Scottish Government and some administrative support from the Royal College of General Practitioners in Scotland. And I also want to mention the legacy and the influence of Dr. Julian Tudor-Hart. Some of you may be familiar with Tudor-Hart. I would say he's been one of the most influential GPs in the history of the UK NHS. He's most famous for the inverse care law, but Tudor-Hart was also the first GP in the UK to measure the blood pressure of all of his patients. And he pioneered an approach which we now call anticipatory care, whereby he wasn't only interested in addressing patients' immediate presenting complaints, the sort of reactive elements of care. He was also interested in their future. He was interested in working with them over serial consultations, so over long periods of time, in their future health and in a proactive way. So he would help them to reduce smoking, to control their blood pressure, to understand and control their diabetes, to reduce alcohol, be more active, etc., etc. And in doing all of that, all of these activities of relationship-based anticipatory care, he was able to demonstrate a 30% reduction in mortality in his community. This was a mining village in the Welsh Valleys, relative or in comparison to one of the neighbouring villages. But his influence, as I said, is most widely known for the inverse care law, which states that the availability of good medical care tends to vary inversely with the need for it in the population served. That inverse care law operates more completely where medical care is most exposed to market forces and less so where such exposure is reduced. So he was partly making a point about the influence of privatization in health, but also more broadly about the distribution and access to healthcare resources. So partly the inverse care law is about where services are, how they're distributed, but also there's elements of it which are about accessing those services and whether some groups in the population find it easier or harder to navigate services. And this is, I guess, to give you some context as to where I'm coming from and also where the Scottish Deep End project is coming from. So we have data here from Scotland. We've updated it more recently, but the picture hasn't changed at all. Essentially, we have steep gradients of healthcare needs. So the blue line is premature death. The red line is a combination of physical and mental comorbidities. And yet we have more or less a flat distribution of resource. So this is green is consultations per 1,000 registered patients, and the black line is funding per patient registered. And this is across the socio-economic deciles. So the inverse care law manifests as a shortage of time in the working day, within consultations, within the working week, to address the extent and the complexity of patient needs. And this has been the flipped to represent the GPs at the deep end. The swimming pool analogy, we're all have our heads above water most of the time, but it's much harder. The GPs at the deep end are working harder, they're more stressed, and they're often struggling to get to the bottom of patient complexity. And this is how the flag has evolved. So this is a kind of logo. It's a Scottish project. There's a thistle at the top of the flagpole. The flagpole itself, the green part, is in the shape of a spurtle, which is a traditional Scottish wooden instrument for stirring porridge. So the GPs at the Deep End project is an agitating, a stirring, and advocacy project as well, advocating for more resources where needs are greatest. And where are deep end practices? Well, the Scottish population is around 5.3 million. We have just under 1,000 practices. Well, now we've got closer to 900, but we used to have, about 10 years ago when the deep end started, it was closer to 1,000. So roughly we have 5,300, 5,500 patients per practice, and you can rank all of those practices based on the percentage of patients who live in the 15% most deprived areas. So this is using a Scottish Index of Multiple Deprivation, and you can see that you have this distribution. So the deep end practices was an arbitrary cutoff of the 100 most deprived practices, the practices where the highest concentration of patients were living in the most deprived postcodes. Even within the deep end, there's considerable variation. So I've worked as a locum in practices here where it's 80%, and that feels much more intense. The complexity is much more obvious than in a practice here where I am currently, where it's more like 40%. And the other thing to say is that, you know, only a third of all of these patients are based in deep end practices, and the 2/3 are registered at other practices across the country. So one of our shifts, if you like, has been more towards thinking about how can principles and practices from deep end be applied more broadly. About 80% of deep end practices are in the Glasgow area. This is a kind of interactive heat map. It's called simd.scot, but it has the 7 domains that make up the Scottish Index of Multiple Deprivation. And you can see that the red ones are the most deprived, and the blue ones are the least deprived. So most of Edinburgh is much more affluent than most of Glasgow, and I'm based here. And I wanted to make a brief comment about some of the limitations of this SIMD measure and other area-based measures. And one of the main limitations is that it's just looking at areas, it's not looking at individuals. So as this infographic demonstrates, not all people experiencing socioeconomic disadvantage live in deprived areas, and not everyone in a deprived area is experiencing deprivation. Similarly, we have people across the remote and rural parts of Scotland, so the Western Isles and Orkney and Shetland Islands, who are not, will have 0% who are registered in the most deprived postcodes, but may still be having, various social and economic challenges. And also just to make the point that this is the 7 domain multiple index, but it maps pretty closely with the income and the health domain. So I suppose the income being one of the main drivers of health outcomes, but also both of them are contributing to that overall SIMD measure. Okay, so what do we mean by health inequalities? Well, I think it's important to be mindful of the different terminology that's used. I'm conscious that in parts of Europe, the term inequities is used much more to demonstrate or to reflect unfairness or an injustice to the health differences. In the US, they talk more about disparities. And that language is starting to come through in the UK as well. We can also think about inequalities of different things. So inequalities of opportunity, inequalities of access, and there's structural and process elements to access, as I mentioned earlier. or inequalities of different outcomes. So typically, I've presented some data on premature death, which is quite a hard outcome. Life expectancy is one of the common outcomes we look at, but you can look at any number of different health-based outcomes. And then there are different axes of inequality, and again, most of my focus has been on socioeconomic status, using this area-based measure, but we can also consider axes of inequality related to age, gender, ethnicity, disability, sexuality, weight status, and so on. And there's various of these models of, I guess, kind of intersectional privilege or advantage and oppression or disadvantage based on all these different axes of individual variation. The concept of intersectionality kind of flows from that, this idea that there's no such thing as a single issue struggle, because we do not live single issue lives, and recognizing the importance of multiple overlapping, interacting identities and experiences, and the links between power, discrimination, oppression. And we're starting to see intersectionality being used more in our understanding and in our analysis of health inequalities. But for today, I'm going to be focusing mostly on socioeconomic inequalities, because that is the biggest issue in Scotland. The unfair and avoidable differences in people's health across social groups and between different population groups. And the way it manifests and its links with health are fairly clear, fairly stark. And so, to my mind, health inequalities is really a shorthand for saying people living shorter lives lived in poorer health. So this is based on nationally representative data for the Scottish population, and it's looking at people with 3 or more long-term health problems or multiple long-term conditions, multimorbidity. The onset of multimorbidity is happening roughly 10 to 15 years earlier in the most deprived decile in red compared to the most affluent in blue. So that idea of healthy life expectancy or years lived in poor health, you can start to see where what's driving that. The relationships between physical and mental health are very clear across the board, whether you're living in a more deprived or more affluent area. There's a relationship between increasing physical health conditions and increasing mental health conditions. That relationship is bidirectional. So as you have more physical health problems, that affects your mental health. But similarly, if you have mental health issues, that can also affect your physical health in various ways, both through different health behaviors and coping strategies, but also often through medications. But the gap is much bigger here. Okay, so I want to spend a little bit of time now thinking about social cohesion, because this is the part, the health inequalities bit is very comfortable territory for me. This is what I've been thinking about and teaching and researching for many, many years, but I hadn't actually given too much thought previously to notions of social cohesion, and this was a challenge from Diedrich to include this in my title. So I thank you, Diedrich, for that challenge. And I started off thinking, big picture. Well, we have these Sustainable Development Goals, 17 goals, which every country pretty much in the world has signed up to and is working towards, and they incorporate big important elements of how are we organizing our economy, how are we living more sustainably and thinking about the climate crisis and the environment, but also society. So they've got these 3 overlapping, interacting elements of sustainability, and this is a huge challenge for every government and every society. But if we look at those SDG indicators and targets, Very few of them actually focus on social sustainability. They're mostly around the environment, the economy, or sometimes different health metrics, rather than sort of social sustainability itself. And I wondered about that, and I think that's partly because these notions are quite hard to measure, and because they're often contested and often vary in different countries, in different cultures, in different contexts. But looking to kind of get a bit more of a handle on it, and what a definition for social cohesion might be, well, the Organisation for Economic Cooperation and Development, OECD, states that a cohesive society is one which works towards the well-being of all its members, fights exclusion and marginalisation, creates a sense of belonging, promotes trust, and offers its members the opportunity of upward social mobility. And this definition captures these kind of probably three core constructs that I think are common to many definitions of social cohesion. So the idea of social capital, the idea of social inclusion, and the idea of social mobility. I'm going to spend a bit more time now thinking in a little bit more depth around social capital and social inclusion. Social mobility for me is a bit more straightforward as a concept. I guess it's just the idea that however we measure it, that that people are able, or it's the potential for people to be able to move, usually upward, from whatever social category they're in currently to one that is viewed more more favorably. So the definition of social mobility, I think, is usually a bit more straightforward, although again the measurement of it is maybe more contested. But I'm going to, as I say, spend a bit more time looking at these two, social capital and social inclusion. So social capital, first of all, and this is packing a lot in, but I like it because it really incorporates the two main ways of thinking theoretically about social capital. So there's a kind of structural level, which is these elements, structural, relational, cognitive dimensions of social capital. And then they've also built in the network thinking of social capital. And you'll see in the following slides as well that although this might look complicated at first glance, there are commonalities. So there's commonalities to do with networks, there's commonalities to do with civic engagement, to do with norms and values, and to do with trust. We see trust here in two different ways, and networks here and here. So those things, trust, networks, values, and engagement, are probably the four main points to think about when we talk about social capital. This US author Robert Putnam popularized some of the thinking around social capital in his book Bowling Alone, and he outlined these three different elements of networks. And you can have strong ties or weak ties within each of these networks. So we have bonding ties for those who are kind of share similar characteristics, either social class or religion or interests, and they can be strong or weak. There are bridging ties, where that's to do with links with either friends or family or acquaintance with different characteristics and different backgrounds. And then there's vertical or linking ties, where this idea of kind of tapping into different positions of power or potential for resource through linking. So to kind of summarize this fairly crudely, you have these, I would say, four main notions. So the networks, the idea of trust, the shared norms and values, and then notions around civic engagement and voluntary activities. And again, there's a range of different ways that these can be measured. So pretty complex. And then to add another kind of layer of complexity, really, in some ways, is that there's various levels at which you can try to conceptualize, theorize, and therefore investigate social capital. You can look at that at the individual or interpersonal level. We sometimes talk about micro, meso, and macro. So the micro would be the individual interpersonal level. The meso would be the group or organizational level, and the macro would be your community or national level. So, for instance, EFPC could consider how what its social capital is and how it links as an organization, and there are different theoretical frameworks that it might use to try to actually measure that. Okay, so on to social inclusion and therefore exclusion, the sort of corollary of social inclusion. Again, it's a contested topic, a contested concept. It's often used without being explicitly defined. It's sometimes linked to particular political ideologies, but definitions do matter, and they affect how the problem is understood and approached. This is a common theme through my talk. So, as with social capital, it's multidimensional, it's context specific, but it usually will include opportunities to realize rights in these different domains: civic, social, economic, interpersonal, spatial. And there are different mechanisms of inclusion or exclusion. And these are just some of them. These are slides that I've borrowed from colleagues in the MRC unit here. So there's a kind of social legitimization processes or social acceptability processes, and elements of stigma or control can feed into either the legitimization or delegitimization of certain social groups. Example here being LGBTQ+ communities. There are legal elements potentially to inclusion or exclusion, legal protections, legal constraints, legal regulations. There are economic processes or mechanisms which can either be inclusive or exclusive. So, for instance, in some of the welfare sanctions or welfare conditionalities we have in the UK, that can be either inclusive or exclusive. Provision of social goods, which are often necessary for the fulfillment of rights or for participation in society. Eligibility for housing, for instance, again, is another mechanism. And there can be physical and environmental mechanisms. So we often use in teaching examples of the social model of disability and thinking around the accommodations and the changes we need to make to our built environment to actually make to level the playing field for people with different disabilities. The challenges with social inclusion is that it's often defined relative to some kind of norm or mainstream, and who defines what that is. Is it binary, or is it a spectrum? Is it static or dynamic, active or passive, subjective or objective? And does it focus on individuals and groups rather than on processes? So we've seen that with some of the examples from above. And also, if we are speaking in terms of individuals or groups, it kind of homogenizes those by speaking about them in those terms, as indeed I have done in parts of my talk so far, and obscures the diversity and the heterogeneity within excluded groups. WHO defines social exclusion as dynamic, multidimensional processes driven by unequal power relationships, interacting across 4 main dimensions: economic, political, social and cultural, and at different levels, including individual, household, group, community, country and global levels. So again, in keeping with those theories of social capital, we have different dimensions and different levels. The result is a continuum of inclusion-exclusion characterized by unequal access to resources, capabilities and rights, which leads to health inequalities. So certainly the ideas and thinking around social inclusion or exclusion are intertwined with ideas of resource distribution and access, capabilities, human rights, and they're also fundamental to health inequalities. And often processes co-occur. So similarly with what we know about the coexistence of long-term conditions or multimorbidity, similarly with what we know about the clustering of unhealthy behaviors, these processes of exclusion can often be intersecting. So we have terms such as severe and multiple disadvantage, or multiple exclusion, or deep exclusion, or in Scotland, in one of our recent reports, it was deep poverty was used, multiple and complex needs. I'm not going to spend a huge bit of time on this, but there have been research and reports focusing on these groups that are most affected by severe and multiple disadvantage. And this is the Hard Edges Scotland report from about 4 or 5 years ago now, which characterised, first of all, 3 disadvantages: so homelessness, substance dependence and offending behaviours, and showed the numbers that were experiencing those different disadvantages. And then they had an expanded picture with 5 disadvantages, including mental health, excuse me, and violence, interpersonal violence as well. So I think it's fairly obvious that if you're experiencing severe and multiple disadvantage, if you're experiencing social exclusion, then that's going to have an impact on your physical, mental and social health. And we see that in statistics. So this is just looking at populations experiencing homelessness in the red box, and then different deprivation quintiles in the blue boxes. And for every condition, whether that's asthma, COPD, epilepsy, heart problems, stroke, diabetes, you have, well, maybe not with diabetes, but for most of the others, there's not only there's a social gradient first of all, but you have this kind of social gradient with a steep cliff edge that's sometimes been described. And from the work with people experiencing social exclusion has grown the field of inclusion health, initially with homeless populations, but that's now expanded to other marginalised groups, defined as a research, service and policy agenda that aims to prevent and redress health and social inequities among people in extremely poor health due to poverty, marginalisation and multimorbidity. Okay, so that's kind of me covered all the definition, but that's probably most of the meat of the talk as well, because the next few slides are a little bit quicker, and we'll definitely have time for discussion at the end. So what's the role of primary care? Well, there's been a huge amount of it's been written about the potential for primary care to mitigate health inequalities, and various different frameworks have been produced. And I'm just going to pick up on one of the more recent ones. This was from the Health Foundation from last year. And they, first of all, they flagged work done in the US, because historically the US and Canada have done a lot more in terms of the role of primary care in mitigating health inequalities. I think that's partly because they've needed to, because the gaps in the welfare state in the US are far greater. So I think that's been a response to need. But they have this National Academies of Science, Engineering and Medicine outlined these sort of 5 A's: awareness. So to what extent are healthcare providers identifying social risks such as food insecurity or housing instability, and assets, and how are they responding? There's adjustment of clinical care, adapting clinical care, providing assistance. So like this would be our notion of social prescribing would fit in with this assistance. Alignment, again, similarly, what's already out there, supports in the community, and how can we facilitate partnerships, how can we join people up? So these are very much within the social prescribing domain. And then advocacy, so that kind of advocacy either at an individual or a community or a policy level. And they went on in this report to set out their own framework for understanding healthcare approaches to addressing social needs. And again, they have broken it down into those that operate within the NHS and those where the NHS is working in partnership with others, and both at individual and population levels. So similar sorts of ideas at the individual level within the NHS, adapting care to account for patients' social needs. So that could be partly, what data are we collecting, and how is that informing our treatment decisions? Using NHS resources to improve social conditions in the community. Again, this is related to access. Connecting patients with resources to address social needs, so very much within the social prescribing domain, and then aligning local resources to improve population health, so joint planning between NHS and local partners. For instance, the big move across many countries for greater health and social care integration. And they note that implementation depends on a mix of system level changes, such as data collection and social needs, something which we don't routinely do now in the UK. Community involvement, staff capacity and training. So there's lots of different elements that primary care systems would need to implement in order to kind of fulfill the potential of this framework. And then just a last point on the role of primary care before I go on to talk about the deep end is from a recent paper in the Lancet Public Health. Colleagues of mine, I was involved in contributing to some of the work, but they basically did a big systematic review of literature looking at how general practice might reduce health inequalities, and they produced these 5 principles. The first is involving coordinated services across the system, so it's connected, accounting for differences within patient groups, intersectional, making allowances for different patient needs and preferences, flexible, integrating patient worldviews and cultural references, inclusive, and engaging communities with service design and delivery, community-centered. So I would say these 5 principles of being connected, intersectional, flexible, inclusive, and community-centered are fairly solid ones to be working on. They're also, evidence-based following this review. And hopefully, as you'll see, they're also principles that the Deep End project have tried to work by. So very briefly, the Deep End started in 2009, first time in Scotland that practitioners working in areas of concentrated deprivation had been convened and consulted. And very quickly, we created a sense of identity, a sense of common purpose and solidarity. There was engagement with practitioners. There was over time a profile and a voice, which led to a range of publications. A range of publications initially, various presentations, and then opportunities arose. So opportunities for demonstrating different ways of working. And these are some of the projects that the Deep End has been involved in over the last 10 years or so. So community link workers is very much within the social prescribing space. Care Plus was an attempt to sort of reverse the inverse care law experimentally. So practices had additional resources to have longer appointments and have more time with patients and do more proactive rather than reactive care. And that was found to be effective and cost effective, but hasn't gone anywhere, has not been implemented. Welfare advice embedded within practice. Governed SHIP was social health and integration project. So this was working with a social worker and social care worker, within practices. And then alcohol nurses and the Pioneer Scheme was a kind of recruitment and retention initiative. The issues affecting deep end communities are familiar. Unemployment, benefit sanctions, cuts to services, poor housing, mental distress, drugs and alcohol as coping strategies, a sense of fatalism, not investing in your health to the same degree, bereavement at an early age, and higher incidence of most chronic illness. And then we know a fair amount about deep end encounters as well, in terms of their complexity, in terms of the shortage of time, the greater stress, the lower empathy from practitioners because of that stress. Lower empathy means lower enablement. Lower enablement is a measure of the extent to which people feel able to manage their health conditions. And everyone has reduced expectations as a result. What we've not really measured, which I'll reflect on at the end, we've not really done any of the studies, any of the previous projects that I mentioned in the earlier slide, haven't, to my mind, tried to capture social cohesion, and that's something to ponder. And I wonder if that's partly because the level of that general practice and primary care operates at is an individual one. We're generally operating in a consultation on a one-on-one confidential basis, and not necessarily thinking in a more socially networked way. Okay, just very briefly, I've got one slide on each of these areas, and these are the 4 main areas of activity that the Deep End has undertaken over the past 13, 14 years. So advocacy around workforce and trying to strengthen the workforce, education for future generations and for existing GPs and other healthcare members of the team, advocacy and research. And all of these have been written up and have sections in the Deep End website. So sadly, the broader context of workforce in the UK is of declining GP numbers and increasing consultant numbers. So this imbalance of generalism versus specialism, it provides the broader context. But the workforce issues, and I've touched on these very briefly, have involved really additional staff who are not GPs, but additional members of the multidisciplinary team that can provide support to people in more disadvantaged areas in particular. And the principles there, the flexibility, being more assertive outreach, particularly the alcohol nurses were successful with this. The embedded nature of additional staff, so for community links and welfare advice and social care, in fact, for all of these, the fact that they're very much become part of the team rather than just co-located within a health service, within a health centre, has been key. And that these resources are targeted to areas of greatest need. Briefly on the education side, we take a whole career perspective. So we have been supportive of initiatives to widen access to medical professions. We've been involved in undergraduate teaching, postgraduate training, and lifelong learning. And these are just some examples, but I can say more about those in discussion if we have time. Advocacy, again, is not for everyone. So one of our PhD students interviewed Deep End GPs around how they understand health inequalities and their roles and scope for mitigation. And everyone recognised their remit and their role within individual care and social care. but not everyone was active or view themselves as being having a role at these levels of policy, politics, community. So advocacy is not for everyone. We recognize that advocacy is not only what you say, but also what you do. So try to kind of, manifest our advocacy through example. But we've done various things to try to improve our advocacy, media training, letters to MPs, network building with other healthcare coalitions. And research, just very briefly to say, kind of similar sort of capacity and network building. It needs to include, we need inclusive research in the deep end, but that's often not valued. So to what extent have we managed to mitigate health inequalities and strengthen social cohesion? Well, I've mentioned most of these. These are maybe some of the mechanisms of social inclusion that they're operating at. Yeah, various different things. But as I say, we've actually, to my mind, not really attempted to make any measure of impact in terms of social cohesion. So key points: most determinants of health and health inequalities lie outside healthcare, but the distribution of healthcare resource is an important and under-recognised factor. It's the inverse care law. Improving the volume, quality and consistency of care where needs are greatest, I think, will mitigate health inequalities. And very few studies have measured the impact of primary care on social cohesion. Thank you for listening. Just to end on a note of optimism, we have now over 15 different deep end initiatives, deep end networks and groups across the world, mostly in the UK, but we also have some in one in Japan, in Denmark, in Australia, and there's stirrings elsewhere as well. So I shall stop sharing and hopefully have some time for discussion.
Thank you very much, David. As you said, I think if anybody has a question, I see a comment from Leah, but it was more.
Yeah, the comment of Leah is interesting, David, because it links to the continuity of care, which is provided by midwives, but for sure also by GPs. And Maria van der Muizenberg, our chair, she delivered her farewell speech last week in the Netherlands, going with emeritus. And one of her advices was to invest in this continuity of care, because GPs who know their patients, who know their environment, who know what's behind all these health problems, they can do very much for these patients. And I think I do not say anything particular, but we see the opposite coming into healthcare. With all kind of locums. You have been working as a locum as well, which is not continuity of care. So how can we counteract on these processes? And in fact, my biggest question would be, why do governments still choose for market forces in the provision of public goods? Why, after your story? Please.
Yeah, I mean, these are two very good questions, Diederik. I don't necessarily have a strong answer for either. I mean, I think I totally agree with you in terms of continuity, and any research that I've read related to continuity has done enough to convince me that, you know, with greater continuity we see reduced mortality, actually. So I think continuity has very strong I think evidence, but we have had certainly in the UK, you know, decades of policies which have favoured access and quick access over continuity. Yeah, I mean, I think that can be influenced at practice level, but in some ways, I think if we really recognize the value of continuity, then we need to build that into either in some way in terms of the funding, or incentivize it some way, or kind of make it a priority in practice. I think, you know, so in my practice, we do value continuity, and whoever's doing the sort of triage, as we have a triage system still, will really try to make sure that there's continuity. You know, we'll find out who have they been seeing, who do you know best, or one of the questions is who do you want to, you know, which doctor do you want to see, or which healthcare professional. But I don't think that's universal, and I think, yeah, I think that needs to be more of a priority. I think with your second question, that's a bit harder to answer. Yeah.
Anybody else who have a solution why governments do still choose for market forces, whereas it's clear that it's increasing not only health inequalities, but also, I think, polarization, which again has a very bad effect on health as well. People choose in the whole vaccination issue. Due to polarization, the vaccination levels are going down in the Netherlands, which is, and particularly in the groups of low social economic and status. There is another question of how the Deep End project allow GPs to have more time with their patients, and why it was not implemented in the end.
Yeah, I think this is a really good question. So most of the ones which have allowed more time have involved more resource, but that's been time limited. So the two that I'm most familiar with are the Pioneer Scheme and Governorship, and both of those involved additional early career GPs who were funded to join Deep End practices. With Governorship, that allowed the experienced GPs to take time out of seeing patients, to have multidisciplinary team meetings, so to work with this extended MDT and to start being more proactive in their approaches. So they were able to implement a whole range of different initiatives related to multimorbidity management, related to reducing unplanned admissions, you know, out of hours attendance, A&E attendance. So they would have the time to work with A&E departments, for instance, to identify who were their kind of frequent attenders, and to come up with a plan for how to support them better in the community. There was polypharmacy initiatives. So all of those were done with additional resource to free up time. Similarly with Pioneer Scheme, same sort of idea. We had these early career fellows, and there was something in it for the fellows, so they had protected time as well, and that was alternated every week between a program of like Deep End medicine, if you like, a kind of a learning program, quite interactive, often with speakers from social work or addictions, or you know, the asylum health bridging team, whatever it was. So very much to upskill them for working in the Deep End, and then they would also work alternate weeks on a project with their practice. So they were providing additional clinical capacity, but then also, again, releasing the time of experienced GPs to do some of this quality improvement, proactive work. The Care Plus was a research study, so it's a little bit different. But again, they had additional funding to allow the GPs to spend more time, and the way that they worked, that most practices would have an upfront longer consultation, so 30 or 40 minutes to do that shared decision making, care planning with the patient, and then often not need so many appointments following that. But you know, why are any of these things funded or not is not always just down to the evidence. There's a whole range of factors that come into play when it comes to decisions around policy, and you know, for good or bad. So the two initiatives that started as deep end pilot projects that have been implemented and rolled out nationally are community links workers and welfare advice. And certainly for the former, the links workers, the formal research evaluation of that wasn't unanimously supportive. It was quite equivocal in terms of the benefits, but yet the policy appetite was strong, and the commitment was made before the evaluation was published that the government wanted to implement them.
Mm-hmm. Okay. Over, you asked this question. You're based in Germany. How do you see the developments of GP time for their patients?
Well, I think the inverse care law is still expanding and taking more speed up in a way. We have also problems with shortage of doctors, as you have shown in general, and then the GP consultant ratio is similarly, as you have shown it, and in deprived areas where I'm working, it's even in a city as Hamburg, where it's very attractive to work, but so we have great underserved areas. So I think all the problems you mentioned, we face here as well.
Yeah. Yeah. Well, I just mentioned already the presentation of Maria presenting what is happening in the Netherlands, and we are at the same page. But the positive thing was there was a big audience. We had a really concert hall full of people, including representatives of the police, representatives of course, social work, all kind of, and the mayor of Nijmegen was providing her a royal. How do you call it? A prize. So it is seen as important. So the work of David, Maria, and you, Ove, it will continue. I think we have to stop, Sophie. It's 2 o'clock.
Yes.
It's a pity. Should I end, or will you end this?
I think
this
you
meeting?
can end. I just would like to invite, but probably you will say it because you have it behind you. But I'll let you finish.
Okay, yeah, because I said already in the chat, David is in fact trying to make to sharpen his keynote for Barcelona with this webinar, and I think we're looking forward for your keynote over there. Please send David some suggestions which he can include in his keynote, because that helps, I think. So that's an invitation, but the invitation is as well to come to Barcelona and to join us over there for further discussion. Thanks a lot, all of you, and looking forward to meet David. Thanks a lot. Bye bye.
No problem.
Ciao.
Take care.
Thank
Thanks,
you,
everyone.
David.